to Dr. Amanda Thompsell. And Amanda, we are very delighted to have you here today. Amanda was a GP before retraining as an older age psychiatrist, and she has worked, or she does work, for a multidisciplinary team supporting older adults in liaison and for care homes. She's currently working in a community service for adults with severe mental illness, and she was the chair for the Faculty of Older Age Psychiatry for over 4 years. So Amanda, delighted to have you here today, and if there is anything that I have forgotten, please do say so when you are introducing yourself. So Amanda, thank you, over to you.
Okay, so I'm a jobbing old age psychiatrist working in something we call a SOAMS team, so a community team seeing older adults with some in crisis, some with long-term enduring mental illness. And I'm also the National Specialty Advisor for Older Adults. And I suppose that's sending the message that the long-term plan was for older adults as well as working age adults. And that's why, we need to make sure that older adults' needs are addressed. I'm also a tribunal member and a non-executive member on a board. So those are kind of 4 different jobs. Before I start, I want to say thank you to colleagues in Greater Manchester who've helped me, and I was able to look at their slides. And I also wanted to thank my colleagues, Dr. Tash Lord and Catherine Dykes, who have just been amazing in their work with complex emotional needs in older adults. So can I have the next slide, please? So in essence, what I'm planning to do, has it moved on? Brad, I can't see it move on. Oh yeah. Okay, so what I want to do is set the context about why we're talking about older adults, then talk about health inequalities. We all know that we must be addressing that, but how does that relate to older adults? Then I think the real question is, so what's different? I mean, older adults, just working age adults who've got older. Well, it's slightly more complex than that. And then I thought I would focus on older adults with complex emotional needs, because that's not something that there's a lot of literature about, but it's very important. And as you know, there are complex emotional needs pathways being developed within your local systems. So we need to make sure they are fit for purpose. I want to mention trauma in older adults, and then briefly, the fact that NICE guidelines are coming out, and the main thing to say is older adults are in there. And then I want to leave you with a few questions to ask yourself. So next slide, please. Okay, so this is a slide with the ONS population of people above 65 in 2020. So here you are, we've got lots of areas of greens, that's only 10%. So that's those young populations in London in particular, but you can see here that on the coasts, older people say, yippee, I've retired, I'm off to the sea. And that's when we see it really in the rural and coastal areas, that there is a lot of greater population of older people. So then we're getting to the dark red will be about 30%. So, okay, you say, well, so what? I'm in this nice bright green area. What of older people? It's only 10% of the population. But just in 15 years' time, this is what the slide will look like. Next slide, please. So anybody who thought, oh, it didn't relate to me, is in for a shock. Basically, southwest England, along with rural parts of the country, will have a population that will be older than Japan. And we all hear that Japan's got an old population. 1 in 3 will be over 65. And of the 3.4 million population growth that's predicted, 3.3 will be in those over 65. So this isn't something you say, oh, well, can we make a difference? Can we, I don't know, go back or start again? No, this is baked into the demographic. It's coming. And that's why it's absolutely essential when you're designing your services that you don't just design for now, you design for going forward, and your population is aging. Okay, next slide, please. So what is it? What about, why am I saying health inequalities? It's absolutely baked into our need to address this, but we don't talk about ageism. And this is a really important area. And we know that where we've got reports from the UN, and it's estimated that every second person in the world holds moderately or highly ageist attitudes. And things like that are really impact. If you think about historically the underfunding, the inability for services to be developed that actually meet the needs of older adults. And then there's work going, well, I know it's back to 2009 by Lund, when they gave the same case history of somebody with depression. The person was a 39-year-old man, and the doctors who read it all diagnosed it correctly and gave him psychological support and medication. And then we had an 81-year-old woman, same history, kind of obviously different age. And then they didn't get anything. Well, it was all dementia. Oh, because they were old. You know, that's wrong. And we really need to be making sure that we really address the needs of older adults. And if you think about it, we come to IAP. How come we're not getting as many older adults being referred to IAP that we'd expect? And again, is that because people just say, well, they're older, so what can you do? And that is entirely wrong, because actually older people, if they get referred to IAP, do better than working age adults. So, okay, so if we're going to address these health inequalities, what is different about the needs? Can I have the next slide? I know the next one is a bit kind of coloured and has got lots of little areas in it. But I want to first of all start with the reluctance to engage. I don't know if everybody else has, but I've got a blue kind of wobbly arrow across the slides. But if anybody else has, I don't know if that's, anyway, don't worry. It's not meant to be there. So let's start. I'm going to kind of work around this little kind of semicircle. So reluctance to engage. Older people are less likely, and in all these comments, they are very broad generalizations. You'll all be able to give me examples where they don't apply, okay? So, but generally, older adults are less likely to come to their doctor saying, I think I've got depression. There's a lot of stigma around it. Still, we're getting people who've where we didn't talk about mental health in the past, and they're still not keen to do so now. So they don't want to bother. They don't want to be a nuisance. NHS is a very precious thing. They'll keep their concerns to themselves. So then we go to number 2, which was the underdiagnosis. I've just talked about that, and there's some great work with Dr. Chu Graham did about the under recognition of depression in general practice, and you'll hear about some further stuff in Dr. Morgan's work. Then the use of social support. They are generally being supported because they often have a lot of physical health conditions, as well as perhaps social conditions, plus potentially less support from either work or from their wider community, because sometimes their friends have died. They are much more likely to be involved in social care and have contact, but then nobody really talking about what their actual needs are from a mental health point of view. Again, mental health conditions, schizophrenia, bipolar disorder, depression, complex emotional needs, all of these things occur in older adults, but they can present slightly differently, particularly with depression. It can often present with more of an agitation and anxiety, and also with physical health conditions. On top of that, they may well have some cognitive problems. It might be that the medications and the physical health conditions are impacting on their cognition, but it can make them a bit more difficult to understand exactly what's going on or to be able to use the resources. Then the physical health conditions, if you've got hypothyroidism, that's going to affect your cognition. If you're got Parkinson's, again, that can affect your mood. So there's lots of different things can impact, and all of those physical conditions impact on your ability to have some medications, because if you've got gastric upset, then as an antidepressant on that which increases the risk of gastric bleeds, may or may not be a good idea. So you need to, there are lots of things to think about when you're prescribing as well, but it isn't all about drugs, but when it does neatly move me on to multiple medications. We know that steroids, for instance, you might be on for your arthritis or for your vasculitis, can then make you hypomanic. So again, all of these things can interact and impact on your mental state. Then there's the different risks. The assessments of risk are often very different. We don't think about as much about the fact that older people often will need for mobility to be able to drive, and we often don't ask them about their driving. What about crossing the road? Are they able to do that properly? What about the risks around further attempts at self-harm, suicide, and also what about the risk of aggression, which is often very underestimated. I've already talked about ageism, then I've talked about carers. When we're talking about the support system, then, are we expecting somebody of 80 to be the main carer of somebody of 70? It's, they have their own needs and they're often forgotten. And then the treatment options, because a lot of the research isn't done on older people, we find that some of the options have to be prescribed offline, and some of the evidence around the psychological therapies isn't as strong. But it does not mean that they shouldn't be tried, because there's a good chance that it will work. Next slide, please. So Selfharm, you're going to have a lot more about this from Dr. Morgan. We've talked about how there is a sense that people don't really say about that, and just talking to the people that I see in the community, there's often been other attempts at self-harm which they haven't really talked about, but unless you actually ask about it in a bit more detail, they're not very forthcoming about it. I even quote Dr. Morgan's paper: risk of repetition if they've self-harmed once is higher. And this is not the same way that it presents in younger people. This really should be taken as a serious attempt on their life, and that they often will really want to die, and yet it's kind of underestimated. Well, it's just self-harm. It was only a few tablets. I remember testing where we had a kind of OSCE for medical students, and the person had taken, I don't know, 7 Zopiclone or something, and the medical student couldn't understand why he had taken such a little dose. But for that man, it was an actor obviously at the time, but he thought it was going to kill him. And so I think that there's something that does come into play here, that older people, their risk of self-harm should be taken very seriously. I know Dr. Morgan will be talking about that. Okay, I've already talked about the elevated risk of suicide. Next slide, please. So we're just talking about, there's been a review in 2019 talking about the possible motivators. And if one thinks about COVID at older people, and I know if you stop to think about it, how often have you actually heard the impact of COVID on older people? We've heard about lots of others, and perhaps we've heard about people with dementia, but we really haven't heard about the effect on the mental health, although Age UK have done some research. And there's been increased bereavements for older people and increased isolation. And then we've got the increased alcohol as well. So all of these things are all impacting on older people, particularly now. So we really need to be aware of that when one's thinking about risk factors. And I think particularly where it comes to alcohol and the impact that has on depression, it's so easy for the lovely retired headmistress to never be asked about her alcohol. Next slide, please. So here are some potential risk factors, again, based on this paper, but I think you probably all know them. Obviously the link with psychiatric condition, particularly depression, and then physical health, being in pain. As you get older, you get more physical health conditions. So you might have one in your 40s, two in your 60s, three in your 70s, going on. And all of these things particularly can impact on your well-being and in your views about and have an impact if you've had 3 or more conditions on your risk of depression as well. Again, I've mentioned alcohol, but here we are, we're talking also about people being isolated, and when they've all moved to these rural areas, they often haven't got a network of support. So I've did in bold complex emotional needs. I think somebody is on. And the reason I've done that is because I just want to focus a little attention there, because this is something that is getting more traction, and I think it's something that you need to be aware of within your local areas. Next slide, please. So why am I doing that? Well, there is increased risk of suicidal ideation. And I know personality disorder is a term that we're not now using, but because of this paper, I felt that we could use it here. But there is a risk of people actually ending up completing suicide. So I think it's something that is being developed. The pathways are being developed, and we know that they need to be developed for older adults. But we did a webinar last week, and older adults have not been involved in those pathways, in most of those pathways. And when we asked how many experts by experience have you had involved in your pathways, we only got 12% who said they'd had any older adult experts by experience. So it's really important that we do meet these needs. So next slide. So this is about needs, it's not about diagnosis. We know that people, older adults are not likely to be given a diagnosis because people haven't really been thinking about it. But when one's looked at prevalence rates, and that's just people looking at how people with complex emotional needs present their needs, but also looking at what's on current caseloads, they're suggesting it might be as high as 10 to 20%. So it might be that it's equivalent to younger adults, and yet what are we doing to provide support for them? But they can present with increased presentation with physical health conditions, and then seeking a lot of support from perhaps other services. And so we don't really actually address their emotional dysregulation and their emotional needs. So it's really important that we do, because there are increased risks of poor outcomes, depression, and then obviously we've mentioned before, potentially self-harm. So I think this is somewhere where within your community mental health transformation, you will be seeing more people coming through, and you need to make sure that the services can meet those needs. So just quickly, why are complex emotional needs not recognised? I think there are several potential. Next slide, please. Yeah, they often haven't got a diagnosis, so then sometimes some of the services need a diagnosis, which, as I said, it shouldn't be. It should be about need. But they've also, the assessment tools are not particularly validated for older people. We then kind of don't recognise the challenges, and that I've talked about before, the distress can present more with physical health and preoccupations than the more obvious presentations that you might get in a younger person. Next slide, please. So I want to mention this because you're all experts in thinking about trauma, but it is still, I'm going to keep coming back to it, it's just not recognised in older people, and it's overlooked. I mean, older people have had a long lifespan. It's not surprising that they have experienced at least one traumatic events in their lifespan. And if one thinks about that, their ill health, the bereavements, the loss of jobs, let alone all of the childhood experience as well. And older people often don't use the term trauma in the same way that perhaps younger people do, and they might fail to report it or even minimize it. But I just think that if one starts off with thinking that it's very likely that that older person has experienced trauma, then one's much more likely to have the correct approach to them and really be thinking about how one can actually meet their needs. Next slide, please. I'll just mention this, although I know Dr. Morgan's going to cover it later. We have not got the NICE guidance out yet, but 7th of September is D-Day for that. What I did see was a draft guidance, and I'm very pleased to see it does talk about older adults. And I've just put in, now I don't know if what I've seen in the draft is going to be exactly what is in the final proper version. So but I would say to you that what I have seen seems very sensible, particularly about paying attention to the presence of depression, cognitive impairment, and physical ill health. Really needs that link between pain and depression is really high. And then really that bit about assessing their social and home situation and their role as a carer. We know that depression is very under-recognised in carers, older carers. And then, we've already talked about this, but the higher risk of suicide following self-harm. So and there are various different bits in this. And one of the good bits that they did mention was really expanding the evidence-based around older adults. So next slide, please. So what would any assessment of an older person, I'm not going to, you're all experts in assessing people who've self-harmed, and I just suppose what would I really want to make sure that any assessment of older adults does cover? Really a lifespan perspective, not just on that just one little area, but really trying to understand the whole of them and their relationships with other people, because that will help in being able to work out what their coping styles and particularly their strengths are. When one talks about older adults, it's often in the negative, in all the things they've lost, rather than the huge kind of resources that they have to have got to this older age and how they've coped in the past. It's an opportunity to discuss experiences, but also to be aware that trauma, we don't want to reenact trauma, and particularly for people perhaps who have gone into care homes and had to have help with personal care and all of that, that could really bring back some of the traumas that if they've suffered abuse in the past, it can really trigger those. So I think it's really giving them opportunities, but also to make sure that we don't re-trigger trauma. And then making sure it covers drug and alcohol. I put Invisible Addicts report because we just know that older people are not asked about their drinking or their illegal drugs, and a lot of them do take it. The physical health is really key. And then again, medication. We know that people with complex emotional needs are often on many medications. We keep on adding and adding medication thinking that will solve the problem. It doesn't. And I think it's really to make sure that we offer people a holistic approach that includes psychosocial interventions as well. So next slide, please. So as I said, we're talking, I've said I'm going to focus on complex emotional disorders, but kind of needs. But I think that we know that there is still a belief that older people can't benefit from psychological therapies, and yet we know they can. And the evidence shows that a range of treatments are effective for older people. Those are the whole psychosocial range, and that goes back to 2012. And there's no evidence that suggests that psychological treatments will not work for older adults. So I think just being very open to that. So next slide. So I think kind of when we're thinking about self-harm and suicide prevention, it's obviously identification, supporting them, and really understanding their motivations, and then putting the support, and particularly the referrals, because these are people that are at serious risk of then going on to kill themselves. So they really do need a very good assessment. And then communities are key. We know the role that isolation and loneliness can have. So then supporting vulnerable adults, and we're talking now about peer support, all of those R's roles within primary care. There's a lot here that could really be engaged to supporting people. And then I know you're going to be hearing about the fantastic work that Greater Manchester are doing around self-harm. So I'm not going to steal their thunder, but it's totally amazing. And then everyone who self-harms has suicidal thoughts should have a safety plan. I think you already know all of that. So I don't think that's, but I just think because it's older people, it's just underestimated, and we just make sure that doesn't happen. So finally, I want to end with some questions for you to perhaps ask yourself. So next slide, please. Are you involving older adults by experiencing in your self-harm pathway design and getting feedback? Is it working for them? Are you regularly reviewing your data? Because if you don't know how many, and I know people are going to criticize me and say, oh, well, it's not about age. Well, we are talking about older adults, and age has to be a proxy at this point. It's all our focus is on older people with the needs that mean that they are fit within that category. But I think if one starts off by looking at how many people you have over 65 in your area, and then looking about how many of over 65s that your service, whichever one it is seeing, and is that actually fitting for what you'd expect? Or have you developed as a support service and a resource that is not actually meeting older people? And you need to think about that, particularly in deprived areas, because we know that older adults in deprived areas are less likely to access. And one's going to be thinking, is your offer very digitally focused? Are you dealing with people who can't actually use that digital? I'm not saying all older people can't, but we know that of those that can't, a lot of them are older and also are in the poorer areas. So you're asking older people the right questions in the right way, and I'm throwing that out. How are we asking them about their health, about their trauma, and do those people who are assessing older people consider the different presentation the person might have? Now, I raise that because we've looked at the HE core competencies, which you can see below, and even within older adult services, when we did the benchmarking, so these are services which are providing crisis support, for example, for older adults. In some of those cases, more than 40% of the people hadn't actually got formal competencies in those areas. So, you know, are your workforce able to consider the differences and how older adults present? And I'm going to shut up there. Thank you for asking me to speak. And if you can I have the next slide, please take down my email address and do contact me if there's anything related to older people's mental health that I can help you with.